Okay, we have reached the 7 o'clock hour. So I am very excited to have so many folks joining us again this evening. This is the 5th in our series of EmergenFC in a series, like I said, of foster parent training. It is April 23rd, and it actually maybe feels like April outside for at least most of the state. Even if we have cloudy and kind of craziness out there, we don't have winter out there anymore, at least not that I know of around this state. So nonetheless, Amy Elke here from the Children and Family Services Training Center. Warm welcome along with our trainer for the evening, Deb DeWitt. I am excited. That was an awesome welcome there, Deb. I love it. Anyways, we are excited to have so many folks, like I said, here this evening with us tonight for another hour of training. Go through a few little housekeeping pieces here. Of course, many of you are here just for the information, and some of you also would like a training hour as well. So we'll kind of go through how that takes place. For those of you who have tuned in for the last 5 weeks, you kind of know the gist here of what I'm going to spiel, what the spiel is. Nonetheless, want to kind of go through it because we do have some new folks joining us, which is wonderful. And so if you were here for the live session, when you log in, I'm able to see kind of your name in the attendee list. And from that, I'm able to create a list, and I take that list and I send it out to all the licensing agencies across the state. So that would include our zone, PATH, LSS, YouthWorks, and tribal entities as well. So all of those licensing agencies will in turn receive a copy of who is all in attendance this evening. With that being said, that's kind of one way for them to track it. If you're a person who likes kind of your own copy of kind of training record, you're welcome to complete the evaluation that I will be emailing out tomorrow. And with that evaluation, at the end of completion, you are able to download a certificate for your own record. So I know some folks are tuning in on kind of, tablets, phones, smart devices that way. You're welcome to screenshot and save it as even kind of a photo that way. Just something for your records. So that was kind of one way we figured we could get that to you. If you're tuning in for a social work CEU, I would ask that you either email me at the training center here or place kind of a little note in the chat box for me to get you that social work CEU. So if you're listening to the recorded session, which I know a number of folks have been doing, I ask that you personally connect with your licensing agency for that foster care credit for that training hour that you'll receive. I am unable to offer social work CEUs for those that tune in on the recorded version. But nonetheless, I can guarantee you that it still would be worth your while and value in education. So encourage you to still watch that recorded version. When we talk through kind of the notion of a chat box and how are we going to be able to communicate with one another, as you know, this evening we already have over 140 again logins, which is 140 households. So with that being said, sadly, the only voices you will hear this evening are myself and our trainer, Deb. And so with that, I ask that you kind of consider using the chat box. And what you can do there is you can make a comment if you have kind of a comment or a thought in regards to what is being trained, or if you have a question on the material or a question on kind of how you receive credit or kind of any question at all, you're welcome to put that in the chat box. So if you're tuning in on kind of a smart device, often on your screen, kind of from the presentation, the PowerPoint that you're seeing, you should be able to swipe left. It's left on most devices as far as I know, and then you should see a participant list. And from that, you should be able to get to the chat box. If you're on a computer, you kind of click on where it says more, usually on the right hand kind of part of your screen where there's 3 little dots, and then that should open the chat box. So usually folks are going to be able to find that. I just see a number of people commenting with kind of who's in attendance. So I think the majority of folks have found the chat box. Worst case scenario, if you cannot find the chat box and you do have thoughts or questions, you're welcome to email us, and I can easily connect with Deb if there's a question you have for her and get feedback that way as well. So no worries, no need to stress. If you can't find the chat box, we're plenty okay. So we are in listen only mode, so I would just encourage you to use that chat box. So now for those of you who tuned in for 5 weeks, you could probably do this part of the training, this 2-minute piece better than I can at this point. but nonetheless, I'm going to do it anyway. So this is kind of where I do my two-part pause. The initial part of the pause would be that guess what? We've done 5 sessions. We have a 6th one planned. So be excited for those of you who want to tune in next week as well. But with this training has really been kind of created as we've gone along. And with that being said, as of right now, we are planning that next week will be our last week in this series. Now, with that being said, you don't have to panic. If there's other things that you're needing, I encourage you still to reach out to our office, and we can certainly pull back together. We just figured, 6 weeks in a row is a lot for folks to kind of tune in and commit to. So we figured we'll give a little break, and then we'll see where things go. And maybe even by that time, we'll have more answers of where things are going to be at in regards to this pandemic. So the series was literally set out, with me and Deb kind of brainstorming of how we could support foster homes in this moment. Of course, 5 weeks ago, I had no idea. Well, it would be 6 weeks ago when we kind of started talking. I had no idea that this is where we would be. Never in a million years would I have guessed this, that sort of thing. So nonetheless, our series will technically be ending next week, but who knows what's to come down the road. We'll see. That's to be determined, as much of everything right now. The second part of my pause is the weight is really weighing on a lot of folks this week, because we are hearing messages like, oh, maybe the state will open, maybe it won't. Everyone has a different opinion on that, and then what that would look like, and I don't even know. Right. Nonetheless, as caregivers, we still have kids at home with the notion of a solid month of school left to kind of attend to. A number of us are working from home. Others are working in the community. And there's just a lot of weight. I don't know why that word kind of resonates, but I just feel like that there's a weight on most families right now. Just kind of feeling kind of the pressure. It is nice that it's starting to be a little bit nicer out, that we can maybe step outside in our backyards and get a little bit of fresh air, or go for a walk, bike ride, something like that. All while keeping in mind social distancing, of course, but we can get a little bit of fresh air, maybe a little vitamin C, which will be helpful. But nonetheless, it's been another long week. So I encourage you to take a moment to pause, kind of ground yourself, take a deep breath. Like I shared last week, taking that deep breath is not going to solve all of our problems or take away the true weight of what's on our shoulders. But I'm hoping it can just kind of have that big exhale. So when you tune in for this next 45 minutes or so of training, that you're able to absorb it. So I'm not seeing any real questions in the chat box. I'm just seeing a lot of comments of folks kind of saying, hey, I'm here, which is wonderful. We're at 155 households, which is remarkable, 5 weeks into a session. So I really just appreciate everyone tuning in, sharing their evening with us by all means. And we can move into training. Now, again, like I've shared, because we have so many people online nowadays. In fact, I was on a training earlier today, and myself as the trainer got kicked out, which was a wonderful disaster, but we rolled through it. So with that being said, we do have this next portion of our training recorded that Deb was gracious enough to spend her time not only this evening with us, but as well to record this session, so we can hopefully seamlessly roll this piece of the training out. So the reason we kind of share that is twofold, that that the technology hopefully will work, cross our fingers, cross my toes. The other piece would be that if you do have a question per se, or a comment, it's not necessarily that Deb can just stop and kind of address that verbally. Deb's been awesome about kind of commenting on those that come into the chat box, but we can't really address it maybe as we have with some other trainings where I've been like, oh, Deb, I have a question for you, that sort of thing. So keep those rolling in the chat box, those questions, those comments, that sort of thing. But we won't be able to stop the training. So I think with that is more than enough rambling by myself. We will go ahead and into our hour of training here, and I will see you on the other side.
Hi, and welcome back to EmergenFC, or Foster Parenting in the Pandemic, presented to you by the University of North Dakota Children and Family Services Training Center. I am Deb DeWitz, and even though it says session 4, it's actually session 5. We're going to be talking tonight about working with kids and parenting kids who have particular issues that make it more challenging when they are in foster care. I call this making sense of alphabet soup because there are so many labels that these children can be given. FASD is one of the things that is utilized now, fetal alcohol spectrum disorders, because it used to be there was something called FAS, which was fetal alcohol syndrome, but then some kids did not meet the entire syndrome, so they were called FAE or fetal alcohol effects, which is why they've now gone to the broader fetal alcohol spectrum disorders, meaning kids all across that spectrum. You may also find it under neurodevelopmental disorder, prenatal alcohol exposure. But mostly, a lot of these kids are labeled JPBK, or just plain bad kid, because many of these kids are not diagnosed. Now, why do we need diagnoses? What difference does it make if they have a diagnosis or not? Well, oftentimes treatment can flow from diagnosis. So if we have treatment, that means that we might be able to order brain scans. We might be able to know something more about what's going on with this child's behavior. Certainly we know that in most instances, there has to be some kind of diagnosis for insurers to pay for treatment. So you may have a child who needs therapy, but they're not depressed, they aren't anxious. So if you're looking at a child who seems to have behavioral problems but doesn't fit into the other mental health categories, sometimes the diagnosis is useful because it means that the child can get the kind of therapy that they need. It can also streamline conversations. So for instance, you might say to me, well, Deb, I can't wait till I get outside because what I'm going to do is I'm going to go out to that box that has a round thing in it. And when I'm in it, what I love to do is I love to go places, and it has 4 other round things. Now, that's a long way of saying, I can't wait to get out to my car and go for a drive. So when we say certain words, the listener knows what you're talking about. So a diagnosis can help us streamline conversations because then people say, oh, I get what you're saying. You're talking about a child who has some brain impacts based on in utero exposure to drugs. Now, it also has some negative things it can do if we diagnose children. It can reduce people to labels. So rather than seeing this as a dynamic, a potentially changing child, people might just say, well, she has FASD, there's nothing we can do. And that's not okay. It might stop further assessment, might stop better diagnosis and treatment. So there are times when someone says, well, she has FASD, that's why she's doing this. And they don't stop to think that that doesn't mean she doesn't also have anxiety or depression or other disorders. So we have to look at differential diagnosis. Could be this, or could be that, could be this and that. So we don't want it to stop our doing further assessment about, does this child also have a learning disability? Does this child also have this problem? The other thing that we want to be sure we don't do is create a sense of limitations. Well, we have to be realistic. We also have to want to continue to help the child to improve as much as they can. Once upon a time, we thought that it would be obvious if there was a child who was born with what we called fetal alcohol syndrome because they had some particular physiological characteristics that made it somewhat more easy to find. We now realize that many children are born that do not have those physiological characteristics. And so what we have to look for are certain behaviors, and we have to look for certain kinds of effects that are going to come out biologically, psychologically, and socially. Now, one of the things we know is that parental drug abuse is one of the most common reasons for kids to be ending up in care. These are statistics that happen to be the most recent ones I could pull up this happened to be from Minnesota. Because we talked in a previous session about how, while we might say that parental abuse or neglect is the primary reason children end up in care, that in fact, there's something that comes before the parental neglect and abuse, and that is most generally, a parent has either a chemical dependency or a mental health issue or both, and they live in poverty. It's that perfect storm of issues that send children to care. Now, while white children are still the largest group in care in terms of numbers, disproportionality is still a problem. Disproportionality means per capita, the number of children who are Native American who are in care are much higher than the number of white children who are placed in care. So in Minnesota, it's 18.5 times more likely that Indian children are going to be in foster care and you can read the rest of this, but what we're saying is that we have kids who are ending up in care because of drug and alcohol abuse, but we have a lot more kids whose parents are struggling with mental health issues, chemical dependency issues, and poverty because their parents happen to be Native American, and because of historical trauma, because of historical poverty, these have been issues that have been building for generations. So the Minnesota report also said that while most placement episodes that began in 2017 had a parental reason, there were child reasons. In other words, while the children wouldn't follow the rules, or in other words, behavioral problems, but those tended to be children who were older, and the highest percentage of placements were still due to drug abusive parent. So if we follow that history backward, don't we think that some of those older children could also be FASD related? Just because they didn't get identified till they were older and having more serious behavioral problems doesn't mean that there wasn't some FASD or some kind of a chemical issue. When I'm doing supervision and consultation with social workers who are working with kids, one of the questions that I always ask is, was there any in utero drug or alcohol exposure? And most of the time, that information has never been gathered. And it should be gathered. In every case, it should be gathered. Now, is everybody going to tell the truth? Well, do you tell the truth about everything people ask you? There's a reason that they stopped putting weight on some states' driver's licenses, because most people didn't tell the truth, and because people gain and lose weight. But many times people don't want to admit something that is shameful to them. Their age, their weight, the fact that they drank while they were pregnant. So you all know what alcohol does. Essentially, it enters your bloodstream, but the blood alcohol concentrations are higher in the baby because the baby can't metabolize as quickly as adults. So it interferes with the delivery of oxygen to the baby. So you already know what that's doing to the brain. Now, it can also harm the other tissues and organs. It can cause permanent damage to the brain as well. And I have to ask you this question, does the baby have any control over this? Well, no, of course not. So when you later are dealing with a child who has these behavior problems, please remember this child had no choice about how it began life. So if you look at the brain of a normal person, A below on this, or A on the left on your screen, it shows permanent loss of tissue. So this is what these children are dealing with. Well, no, I got it backwards. So A on the left is what we would call a normal child, and B and C are children who have FAS. So it shows where, now I can't read these x-rays, but it shows that there is a change in the child's brain, that there's literally a change in the child's brain. This is not a choice. This is biology. In the same way that you can't change your height, you can't change the color. Well, of course you can change your height. You can put on high heels. You can change the color of your eyes because you can put on contact lenses. But you get my point. There's certain things you cannot change about yourself, and this is something that these children cannot change. Now, there is some plasticity, neuroplasticity in the brain, which means that the brain can develop some new pathways. So we continue to try to help all children to grow and develop and change for the better. But we are not going to be able to develop all new pathways for some of these children that are going to result in their ability to be just like everyone else. So let's take a look at how we look at diabetes, and let's contrast that with how we look at a child who has fetal alcohol spectrum disorder or a related disorder where there was some kind of in utero drug exposure. In diabetes, we recognize it as a biological problem. For these children whose parent or whose especially mother was using, many times they're not diagnosed until later, if they're ever diagnosed. And so they are struggling with a problem that is unrecognized. In diabetes, there's a biological solution. For FASD, at this point, there's not a biological solution for these children other than how we attempt to help retrain their brain. But again, retraining is not the same as having it perfect or normal from the beginning. in diabetes, we know there's going to have to be treatment and support forever. Oftentimes, what we see with these kids is we expect them to go to therapy or be on some kind of behavior program, and they're supposed to get over or get better or be able to do this on their own. Even though we know for biological issues, many times they're going to need treatment and support forever. That's oftentimes not what we expect for these kids if they're undiagnosed. Now, a person can do lifestyle changes with diabetes. But you know what? Many don't. So first thing they tell people who are diagnosed with diabetes, lose weight, get exercise, eat right. And yet, most people I know who have diabetes at best do one of those. They try to eat better. So that's a choice that people make, even though they know how dangerous diabetes is. And children don't have that same ability. If they would just change this, then it would be better. So they are often seen as the problem because of behaviors they're doing when this is not a choice they're making. Now, the other problem is that, of course, with kids, there are often comorbid problems, which means there are problems that exist in the same place. Just because you have diabetes doesn't mean you can't have high blood pressure. Well, just because you have FASD doesn't mean you can't also struggle with depression, anxiety. And in fact, it's much more likely that these kids are going to struggle with more than one thing. So with diabetes, you're probably still going to have diabetes. I've talked before about, I do know somebody who lost 100 pounds, started exercising, and she no longer had diabetes. But if we have chemical-related brain changes, you're still going to have brain changes. Even losing 100 pounds isn't going to change that. So in diabetes, most people learn about how to live with it. Most do not get rid of it. And so with these kids, it's about learning how to live with it because they're not going to get rid of it. So if people with diabetes make all perfect choices, it goes better. Well, if they could make all perfect choices, it would go better too. The difference is, well, let's go back to diabetes. The people with diabetes whose brains work okay do not make perfect choices every day, all day anyway, do they? Even though they could, they do not make that choice. So what about a child who's got these brain changes that are out of their control? They're not going to be able to make all those changes, and B, even if they could, they're human beings who wouldn't always choose to make the right and perfect choice. So they have a way bigger struggle. Because again, people with diabetes have no brain damage. And so what are we asking you to do for these kids? We're asking you, because they have significant changes in their brain, to help create better environments so they can be successful. So what happens if there is drug or alcohol in utero damage? It can lead to brain and central nervous system problems. What are some of those problems? So look for these in your kids, even if they haven't been diagnosed. Do they have poor coordination or poor balance? Do they have intellectual disabilities, learning disorders, delayed development? Do they have poor memory? Do they have trouble with attention and with processing information? Those are two different things. One is, can I attend to or focus to what you're saying? The other is, can I take in the information you're telling me and make sense out of it? Do they have difficulty with reasoning and problem solving? Do they have difficulty identifying the consequences of their choices? So when you say so some kids say, what were you thinking? And the kid can go, yeah, I know. This child is like, they have poor judgment skills. They may be jittery or hyperactive. They may have rapidly changing moods. Now, again, when we were talking about differential diagnosis, could be this or this. You can have a kid who's just clumsy. That's clumsy. You can have a kid who's hyperactive. That may be ADHD. You can have a kid who has a learning disability. That may just be a learning disability. But these kids tend to have many things on the list. It's not one thing. It's many of these things. And that's what leads us to begin to say, I wonder if this could possibly be some brain interference by drugs in utero. What else? What are you going to see in terms of behavior problems and they're not necessarily present at birth, but they can result from fetal alcohol syndrome disorders? And those secondary disabilities, we call them, could be things like ADHD, aggression, inappropriate social conduct, breaking laws and rules, certainly alcohol or drug misuse, mental health disorders, problems staying in school or completing school, problems with independent living, problems with employment, inappropriate sexual behaviors, even early death by accident, homicide, or suicide. So these are things that can follow for a child as they move through their life if they have these kinds of disorders and it goes unrecognized and we don't attempt to intervene in the best ways that we can. So again, you may be seeing some of these kids, and again, if the child has one thing, maybe the child does just have ADHD. But if you have an ADHD child who is also having problems with independent living, sexual issues, and many of the things from the list before about not learning from past mistakes, difficulty with judgment, that's when we start to say this could be something that could impact them throughout their life. Now, remember again, alcohol is not the only drug. Any substance can affect prenatal development. Smoking, it is funny how they say, well, marijuana is the gateway drug. Actually, smoking, we now realize, is the gateway drug. There's almost nobody who is an addict to alcohol or any other kind of drug that didn't start with smoking. Now, that doesn't mean that all smokers move on to that, but it is interesting that we are now understanding that smoking is in many ways a gateway drug. But any substance can affect prenatal development. Prescription drugs, even those that are used as prescribed, can impact a child in utero, which is why they're so careful what they give you during pregnancy. But certainly street drugs, which haven't been checked out by the FDA, have a ton of things that they can do in utero. Now, not only is it that the drug itself can cause problems for the baby in utero, but if there's a mom who's using, she is much less likely to have adequate nutrition, much less likely to go in for prenatal care. And so that also leads to problems for the child. It can also lead to hypersensitivity to touch for these babies, which leads to bonding issues. Certainly, it can lead to early neglect and abuse experiences, because if I'm high or coming down from a high or passed out, I'm not doing my best parenting. Mother can fear potential prosecution and loss of her children. So oftentimes, even though they realize there's a problem, they're afraid to seek assistance because guess what? They're afraid they're going to lose their kids, which they do. So once upon a time, we had situations where if a mom needed treatment, she could go to treatment with her children. So she didn't have to fear having people find out that she needed help because she wouldn't lose her children. But those days are gone. We no longer fund those centers. In spite of the fact that they were more successful, we don't fund them because we as a society have decided not to. But just as the child has no choice in any of this, addiction is not a choice. Now, again, many of you have been raised with a belief that addiction is the choice. I know somebody who just decided to stop drinking, and he did. Well, then what you're saying is his choice of treatment was a choice. But very few people who are addicts grew up thinking, God, I can't wait to become an addict. Many people, and again, you may know a story of someone who just quit, and that's great. I know hundreds of stories of people who tried and tried, parents who tried to quit and were not successful. So while we can focus on the one person you know about, there are far more cases of people, true addicts to alcohol or drugs, who have not been able to quit. So what does all this mean? What it means in your house is that when you're having a conversation with a kid who meets a lot of that behavioral criteria that we just talked about, doesn't seem to be able to learn from mistakes, doesn't use good judgment, has difficulty with focus, all of those things that we just talked about. And yes, Amy can get you the information that's on this PowerPoint if you would like it. If you've got a kid who's exhibiting all of that, doesn't have the FASD diagnosis, But if they're exhibiting all of that, it may be a child who has fetal alcohol spectrum disorder. When you're talking to that child, well, they look like this. And you think, I am talking to this child. That's not what's really happening. You are actually talking to this. You are talking to the brain that has been impacted by in utero drug or alcohol abuse. Now, I'm not going to go through this whole thing. I just want you to understand that this is 3 different parts of the brain, and each of these different parts of the brain impact different things, everything from muscle movements to sleep cycles, to touch and vision and hearing, reasoning, emotions. I mean, the brain is in charge of all of that. We like to think the child is in charge of all of that, but that's only true if the brain can process it correctly. If a child has damage in any of these sections, the child is not going to be able to process those things in the same way. So you're also talking to all of these parts of the brain. So there are all these different lobes, and they have to do with personality and behavior and emotions and judgment and interpretation of language and words and touch and memory and understanding language. And I mean, when you think about what the brain has to do, and then you imagine, what if the brain gets damaged? And not one part of the brain, but probably multiple parts of the brain have been damaged. So why do we bring this up? Because we want you to understand, again, that with some kids, their behaviors aren't about, I won't, they're about, I can't. So if you had a child in a wheelchair who was not able to walk, you wouldn't get frustrated. If you said, get up and walk your clothes over to your room, you wouldn't be frustrated if they didn't get up and walk. In fact, you wouldn't even say, get up and walk your clothes over to the room. You'd find another way to have the child meet your expectations. You'd say, hey, can you, here, I'm going to put these clothes on your lap. Can you get them over to your room? Can you wheel over to your room and put them away? And you would have made sure that the drawers were such that he could reach the drawers he or she needed to get into. You hear the difference of how, if we can see what a child can't do, we modify our parenting. And that's what we're trying to get you to think about here. There are some of these children who, it's not a matter of they won't, it's a matter of they can't, or at least they can't yet. And so we have to modify our expectations and manage the environment. And hopefully over time, depending again, there can be, it's like, okay, I wear glasses. I have a friend who wears glasses, but I can drive with my glasses. She's legally blind. She can't drive at all. So having poor eyesight exists on a continuum. We've talked about things on a continuum. FASD exists on a continuum. So we can't say, well, a child has FASD, therefore they can't learn, but they're going to learn differently. And some of them, if they're at the very worst level of damage, are going to have difficulty learning. It's going to take a long time, and there are some things they will perhaps never be able to do individually and on their own. All right, I know this is a lot of words, but what are some of the discipline issues? Well, consistent discipline and structure. And they're the key because they have trouble learning and they have trouble following societal rules. So we have to make sure that we are consistent. So other kids, we can say, well, today we're going to skip doing this because it's a snow day. For a child who has trouble learning and trouble understanding slight differences, they may do better if you don't have as much flexibility. Remember, throughout this, I've been saying you've got to know your child. There isn't an answer for every child because you've got to pay attention to what works with this child. So for a child who has difficulty with transitions or difficulty learning how this is a little different from this, it's going to be more important to try to keep things the same. Some people with FASD have a difficult time internalizing morals or ethics or values. So you want them to be able to think through what they're going to do, but it's harder for them to understand how society would see it. Now, again, not all, but if you've got a child that really doesn't seem to be able to take in and respond to what other children have been able to do, then you may be dealing with a child who's got some brain damage from in utero exposure. And it's not that they're not willing to modify their behavior, it's that they can't. So that's what we're trying to get you to look at. Not that you don't have expectations of foster children, but, you know, as somebody said, what about when you get that 1 in a million kid or 1 in 100 kid or whatever? Well, you have to look at, this may be a child where it isn't that they won't modify it, it's that they can't. And so then how do we modify the environment? Some individuals who have brain damage are unable to learn from past experience. They will do the same thing over and over and over, no matter how many times you consequence them. And you think, why don't they learn? Because they can't learn from consequences. So, you know, we have words in that. We have words for that in social work. People who have no ability to learn from consequential thinking. And so, again, what we try to do is not to expect that they're going to learn from it, but to teach them the pattern of what happens. So it isn't so much that when you say, well, why did you do that? They don't know. But if they know that every time they do this, this happens, then they may be able to do less of it, not because they've learned from their mistake, but because they know what to expect. So learning to live with and abide by society's laws and rules can be a lifelong process for some people who are affected by maternal chemical use. So we start with that teaching and discipline in early childhood. And like with, if you know somebody who has type 1 diabetes as a child, that's going to be with them probably throughout their whole life. And they're going to need insulin every day. And they're going to need somebody supporting them when they are trying to learn how to manage that. And they are going to make mistakes too. And so again, thinking of it as a medical condition rather than a series of choices. A rule of thumb for parents or staff who are working with kids that you suspect maybe FAS or FASD is to think younger. So we've talked before about how with some of these kids, they might be 13 years old chronologically, but they act like they're 8. Or they might be 16, but they act like they're 12. Or they might be 9, but they act like they're 5. So oftentimes we have to try to figure out, is it that they're developmentally stuck because of trauma that's happened in their past, or is it that there's some brain damage? And again, I'm not talking about they're unable to learn schoolwork, but they may be unable to manage and finesse some of that, some of those societal expectations of what's expected for them. Some of you have now become more familiar with children who have autism. And, you know, the wildly popular Sheldon character from, what is it called? Big Bang Theory, right? And we see how he can't figure out human relationships. It just escapes him. So you can have, a good ability in one area and not have a good ability in another area because it depends on how your brain is wired. And so for a lot of these kids, you just have to you have to parent them as if they were younger. Now, you try to establish and maintain the same rules for everybody in the household, but you may have to adapt or change some consequences. So everybody has to do this, but with a child who's got some brain damage, in the same way as a child who is in a wheelchair, you may have to modify how you expect and when you expect that to happen with children who are, in a sense, in a brain that's in a wheelchair, right? A brain that is unable to do all the things we want it to do. So again, be consistent, but pick techniques that you're able to follow through with. Remember that no technique is going to work with every kid, that FASD exists along a continuum, and every person is different. So if a technique isn't working, don't just keep trying harder. So if somebody said to you, you need to be firm, you need to do this, you need to do that. If you've tried it and it's not working with your child, then change what you're doing. Redirect the inappropriate activity to something that's safer and more acceptable. So I've seen too often that someone thinks, well, this worked with that child, or this works with other foster children, or this works with other biological children. That doesn't mean it's going to work with this child. So again, child in a wheelchair can't run around the bases. They can get around the bases, but it wouldn't really be fair for them to get thrown out while they're wheeling themselves independently around the bases. Somebody might be able to push them around the bases. I mean, you see what I'm saying? That we have to think in terms of how can I support this child to be able to participate in rules that the family has, in expectations that the family has, but understanding that it's going to take more work on my part. With some of these kids, if you have a prearranged gesture or signal, it can help the child understand what they need to stop. And this is not just true with kids who have FASD. ADHD kids, kids who have whatever, meltdowns. Sometimes if you have a prearranged signal, it can help. And whether that signal is you blink the lights, or whether that signal is, a stop sign, or whether that signal is you just go la 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 at the top of your voice. Now again, if you got somebody who's sensory disordered, that's not going to work. But you got to look for what works. What helps the child? For some children, it's grabbing a blanket and just putting the blanket around the child. So looking for some kind of gesture or signal to help the child to stop, to reset. Because again, many times this is not a matter of I won't do it, it's that I can't do it. As we talked in other weeks, keep corrective instructions concrete. Don't say, clean up this mess, but you got to be very specific, especially with these kids who have some wiring that doesn't work quite right in their brain. You have to be very specific about what you want and how it should be done. Discipline has to be immediate, not delayed. You can't say, well, you can't go outside on Sunday, and we talked the other day about it can't be something that's so long that the child can't imagine it, right? You can't go outside for a week, whatever it is. But you've got to be sure that it is connected very quickly. So whatever happened, then the consequence happens now, and it's a short-term consequence because, again, they're not going to remember something that's long-term. As much as possible, make eye contact with the individual when you're giving directions to correct behavior. But again, every child's different. So if your child that you suspect might have some kind of chemical exposure in uterus, but also has some autistic features, is on the spectrum somewhere, that eye-to-eye contact is probably not going to go. So again, you got to think about your own child, but as we look at kids whose brains work differently, oftentimes getting them to focus with you, so that might mean looking at you, that might mean that you're touching them in a way that is comforting and that draws their attention, can be helpful. Using a calm voice is important. Many individuals with FASD will interpret discipline from whoever it is as yelling. So they're going to react and get defensive and upset. So staying calm is important. Now, what happens when you got a kid who has FASD and ADHD? Because last week I was talking about, use voice variation and that. Well, again, look at what works for your child. So somebody can tell you what to try, but everything is only a try till you see what works. Avoid threats, be brief, don't lecture. Oh my goodness, you'll learn that the first week when you're doing foster care, because lecturing is a waste of breath. Not using physical discipline. Now, I know that you already all know that because it's just not even allowed in the state of North Dakota in foster care, but people with FASD tend to model what they experience if it's negative. Now, here's a really hard thing. And we know this from research. People internalize negative experiences and emotions and memories, and the brain actually stores them differently than positive memories and emotions. So negative memories and emotions get stored in a way that it's harder to forget them. So when it says here, people with FASD model what they experience, what you hope is that if you model hugging and kissing and loving and being patient and kind, then they will do the same. Not necessarily. So they will model negative things. So if somebody hits them, if one of the other kids hits them, they're very likely to hit back, and they're more likely to continue to hit. So as much as possible, we try to avoid doing physical negative things with these kids because of how it ingrains into their brain. Now, never forget this, and this is true of all kids. Negative or inappropriate behavior, or what we call acting out, can be a symptom of a physical unmet need. You know, in the 12-step program of AA, they say, watch out for HALT. And HALT stands for hungry, angry, lonely, tired. So if you've got a child who doesn't have good self-control, who's got some brain misfiring, that hungry child, that is no time to be trying to teach a lesson. If that child is angry, you're not going to get through to them during that meltdown. If the child is lonely or has unmet emotional needs, it's going to be very difficult to get through to that child. And if they're tired. So most of the time as parents, we know that the best time to be doing our parenting is when they are not in those 4 states. So you do what you do to stop the behavior, and there will be a consequence, but you're going to talk about it later when the child is not in one of those 4 states. And we have to anticipate dangerous situations where this person could get into trouble. So learn to recognize the early signs of trouble and to plan ahead. Remember when we talked in an early session about don't just focus on the behavior and what's the consequence, but focus on the antecedent. So if you know that for this child, it is always a trigger if somebody grabs something from him, if somebody gets into his bubble, then you might have to teach all the kids about bubbles. And there are ways to do that. If you look it up on the internet, there's all kinds of ways to do that. You get everybody a hula hoop, and everybody sits inside their hula hoop, and you talk about this is what a bubble is, and everybody's bubble is a different size. And some people don't like you being in their bubble, but other people like you to go into their hula hoop, la, 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 right? So, but again, one of the most important things is that you pay attention. When does this child kind of lose it? And how can you help avoid that so that we can have the most positive experiences that there can be? So we try to avoid, I know a little guy who has some sensory issues. So if mom or dad has to turn on the blender, they know that's going to end up with just losing it. So what they've done is when they're going to turn on the blender, they say, okay, everybody's going to sing really loud. Because if he is singing really loud, the sound of the blender does not impact him in that same jarring way. So they prepare ahead of time for something that they know is going to be difficult. So again, we've got to focus on what are the antecedents? What are the things that's going to get this child in trouble or that's going to cause a problem? And how can we in some way try to figure that out ahead of time? How can we make the environment more calm, less likely to trigger something? Now, we want to remember again, no matter how well you do, whatever it is you do, you cannot erase the damage. Okay? The child was in an accident and his spinal cord was severed. At this point, we are not able to help that child to walk again. However, there are many things that child can do. And this is how we look at this. Okay? We can't erase the damage of what happened, but we can hope for new pathways to be developed that will help for the child to get better at what they do, to understand better, but we're not going to be angry at the child for something that was out of their control. Because with repeated interactions can be learned. When this happens, that happens. It doesn't mean the child is going to internalize, I don't want to do that, because this is what we want our kids to do, internalize our morals, internalize our values. For this child, it's much more likely to be just when this happens, that this happens to me. And again, it's not consequential learning where they say, well, then I won't do that anymore. But over time, they're able to associate those two things. So in many ways, it's like working with a child who has a cognitive limitation. You know, your child who has no cognitive limitations can learn the times tables in a fairly reasonable period of time. Child who has cognitive limitations will still be struggling with the multiplication table, maybe into high school. So what we have to be is entomologists. No, I got that wrong. What we have to be is not entomologists, but geologists. What do I mean by that? An entomologist studies bugs. So I put here a housefly. Now, why did I put a housefly? Because houseflies live maximum about 2 weeks. I know it doesn't seem like that. It seems like they live forever, but they really only live about 2 weeks. And sometimes we kind of are like houseflies. We want to try something for 2 weeks, and if it doesn't work, we don't want to ever do it again. Now, I am saying pay attention to what works with your child and don't just keep doing the same thing if it's not working. But we also have to have some consistency so that if you see it working a little bit, then you continue, right? You're shaping a behavior. You're shaping a behavior. But we have to think of our family and our world in the way that geologists think of the world, not 2 weeks at a time. But what happens if you do something over time? And what you see there is a picture of stalactites and stalagmites. And how are they formed? They are formed one drop at a time. One drop of water at a time, and the water evaporates, and the minerals from the water are left behind. And over time, one drop at a time creates stalactites and stalagmites that weigh tons. And that's how you think of yourself. Not in this 1 year that I have this child, I'm going to solve all of their problems. But I'm going to be that one drop of positivity, that one drop of encouragement, that one drop of understanding, that one drop that helps this child to move, even if it's just, even if the stalactite only grows that much. It is better than someone who knocks it over by doing things that don't work and the child feeling worse because they feel like a failure. So we have another short session today. Hopefully you will have a chance to either ask us some questions or to chat in the chat box. I hope this has been helpful, and we will turn it back over to Amy.
Okay, another great night of information by all means. Wondering what questions, we have a little bit more time tonight than we maybe had in the last couple of weeks. So wondering what questions folks have or comments. I know there was some chatter in the chat box, which is always great to see. I don't know if anyone has any comments or Deb, if you want to offer anything else.
Well, I'm just going to thank Jane. For those of you who've been watching the chat box, Jane Brown put a link to a report that you could look at that relates to children who live with parents who have substance abuse disorders. And somebody did ask a little earlier, somebody asked about, well, what about kids that get exposed when they're not in utero, but they've been born and now they have parents who are using? And I said, well, I don't really know that research. I was responding more to the biological impacts. Certainly, we all know that parents who are using, that can have a very negative impact on children. What you tend to get if parents are using is, in fact, and again, everything's on a continuum. So when I say using, there are probably people at this meeting who have a beer from time to time. That is using drugs. There are people who drink coffee. Coffee has caffeine, which is in fact a drug. So we have to be aware that we're not just saying anybody who uses any kind of a chemical, but for people who are addicted and for whom that addiction takes over their lives, we know that, that many times they end up neglecting their children because of that addiction. And so we know that neglect has a very significant impact on children. Certainly there are some people who respond, let's just take alcohol, you know, let's be honest, in North Dakota, we have a very high drinking rate in the state of North Dakota. So most of you know somebody who has a problem with alcohol. And there are some people who just get mellow, but there are some people who get really argumentative or who get angry, or, you know, you've heard the phrase mean drunk. So again, for children, if they're living with someone who is using any kind of substance, whether it's alcohol or other kinds of street drugs, you know, they are at the mercy of that parent, either if the parent becomes angry or violent or neglectful, or passes out, whatever. So, you know, yes, there are many negative impacts that can happen. On the other hand, we do know that that exists on a continuum. And so, you know, I guess I've said enough.
Yeah.
So other questions or comments?
Yeah, there was another one that came in the chat box here. It says, if you have suspicions of fetal alcohol syndrome or in utero exposure, but can't get a direct answer out of anyone, how would you go about that situation? Would you just assume and get therapy?
Well, you know, and again, I don't pretend to be the biggest expert on this, you know, and we have two dilemmas, because right now we are in EmergenFC, meaning that what we might have been able to do when there wasn't a coronavirus may be different. So, you know, here's old lady Deb DeWitt, who was supposed to have her cataract surgery, and she can't have it because she can't go to the doctor, right? So it is going to be more difficult right now to try to get answers. But I would say this, it is very difficult to get answers because it's one of those things that, you know, I began by saying once upon a time, we thought that all children who had fetal alcohol syndrome would have the look. And then we came to understand that's not the case. And certainly fetal alcohol effects, there is no look. So, you know, what you do is you try to ask your provider if you have suspicions, if you take a look at the things that we see in fetal alcohol effects or FASD, and you say, golly, this really kind of fits my kid. And again, not one thing, right? Just because you have one thing, you know, if you have one mole that changes, that doesn't mean you have cancer. But if you know the 7 signs of cancer, then, you know, if you get 3 or 4 of them, you're certainly going to be going, oh, okay, there's a problem. So again, if you see several of the things on this list, then talk with your providers about it. And it is okay to ask providers what they know about FASD, because not every mental health professional has a lot of knowledge about FASD. Not every child psychiatrist may have as much knowledge as you would like. So, you know, you keep asking. But I do think that, and I've tried to say this in multiple ways during this training, that part of it has to be that you have to pay attention to what works. So when you say, would you just assume and get therapies? I think what we all try to do is to look at, well, what's working with this child and what's not working. Because what's therapeutic is finding what works for this child, whether the issue is ADHD or FASD or RAD or whatever the alphabet soup is for this child. You know, really, when I started out and I said, you know, I'm going to go get in that thing that has a round thing and then it has 4 other round things underneath. The reason we use words like a car is that it makes it easier to communicate. However, look at all the different kinds of cars there are. And not only are there cars, well, there's also trucks, and there's also SUVs, and there's also motorhomes, and there's also horse trailers. And you know what I mean? There's so many different ways to be transported. And so with kids, while we would love to have the answer, this is what makes this child do what he does, let me ask this. Do we even understand ourselves? You know, do we even understand what motivates us? That, you know, one of the things I say sometimes in workshops, people will say, you know, well, why can't this child just learn? Why can't they? And I say, well, let me ask you a question. Have any of you ever been on a second diet? And when I ask that question, everybody laughs. And I say, no, I don't want you to just laugh. I want you to raise your hand if you've ever been on more than one diet. And almost always, 2/3 to 3/4 of the people in the audience raise their hand. It's like, okay. My mom said to me once, you know, Deb, losing weight isn't that difficult. East, west, north, or south, to diet best, just close your mouth. Now, okay, that sounds simple, right? So why is it that if we know that really to lose weight, all we have to do is not eat, why do we as Americans tend to have a problem with obesity? Because human behavior is very complex. Our own behavior is very complex. So it is difficult. It is hard to know. Somebody said, Julie and Cliff said, it's hard to know what's a behavior and what's an FASD issue. And that's true. It's absolutely hard to know. I think the way that we try to get people to think about it is, most of us don't get up in the morning and think, I'm going to be a jerk today. I'm just going to make everybody's life miserable. But we might find during the day that we get stressed, or we've talked before about people who get hangry when they're hungry. They struggle to rein in their emotions, that we might have some of our own behaviors during the day. And so what we're trying to get people to think about is, what do we even mean when we say, well, this kid had a behavior? Everything we do all day long is a behavior. But when we say this child had a behavior, what we really mean is this child did something he wasn't supposed to do. I didn't want him to do. And yet most human behavior has some purpose. Now, you may not understand the purpose, because your purpose is, you know, I wanted you to go to the table. But in that child, the purpose might have been created inside that brain that doesn't work like yours does. So if this is a child who has trouble transitioning, and you say, go to the table, and he has a meltdown, one could say, well, that's just a behavior. It is a behavior, but that behavior is created by a brain that does not switch from one thing to another. So when I'm working on my computer, and you know, we talked last week about my being ADHD, I think it should just go from here to there in 1 second. Well, it doesn't always do that, because sometimes it has to finish what it's doing before it can move into another process. I can't have too many things open at once. And for this child, that may be the problem, is that in his mind, he had to finish doing that Lego set. And when you said, come to the table, his brain cannot transition that quickly. And so when he has what you would call a meltdown, you could say, well, that was just a behavior. Well, yes, but that behavior was created by a brain that cannot switch in the same way that some people's brain can switch. So it is really hard. So, you know, kind of one of the things we're trying to do is to say, rather than looking at these things as behaviors, let's look at what might be going on inside my child's body, what might be going on inside my child's brain that makes this so difficult, that would make him do something that's going to end him up in trouble. Because you know what? None of us want to be in trouble. So, and it is hard when schools say, I don't know how to deal with an FAS kiddo. It is very difficult. And yet, a teaching degree is 4 years. And, you know, a social work degree is 4 years. When I went back for my master's degree, I had 2 more years where all I did was study human behavior. And so you've got a teacher who's got a 4-year degree, and that 4-year degree teaches us as teachers how to deal with mostly the average child and an average classroom. We have more and more kids who have problems that are not average. And so it is hard. It is hard because teachers don't always have all the information they need. But many teachers go back and they continue to get more education. And yeah, it is hard if people are defensive. So do they ever come out of a learning disorder? Now, learning disorder can mean many things. Once upon a time, a learning disability was a specific topic, meaning that like I had, what is it called when you goof up letters? I must have that one. What's the reading disorder called? Somebody help me out here. Dyslexia. Yeah, I was going to say dyslexia. Yeah. Like that was considered a learning disability or learning disorder. And do you ever outgrow it? Probably not, but you learn how to cope with it. So let's again, I'll use myself as an example. Did I outgrow my ADHD? No, but I learned how to cope with it. I learned how to harness it. I learned how to use it to my advantage. And so again, do people come out of a learning disability or learning disorder? Do they come out of having FASD? They don't really come out of it, but with positive help, they learn ways to cope with it. And they can learn some strategies that help. But again, it exists on a continuum. Is this that 1 in a million child? So you've got some kids who have a little bit of impact from parental usage. You might have another child who's significantly impacted because there was a lot more usage throughout the whole time of the pregnancy. So again, we can't say an FASD kid because they are all just as different as you and I are. So, you look at Amy, she looks 10 and beautiful and gorgeous, and I look like a ghost, right? Well, we're both female,
hilarious
social workers. We're all and so, these kids will all be different. So what we want you to do is just try to accept them for who they are and how they are, in the same way we would accept a child. We wouldn't say a child who's got MS. Well, children don't tend to get MS, but a child who had muscular dystrophy, we wouldn't get upset if they didn't stand up for the Pledge of Allegiance. We wouldn't be upset with them if they didn't stand up out of respect when we sang the Star Spangled Banner. We understand that's not a behavior, that's a condition. Mm-hmm. And that's what we're trying to help you to look at, is that for many of these kids, the things that people see as behaviors really are conditions that the child struggles to overcome.
Deb, someone had made a comment to me privately asking that they said, if an infant, and they literally put normal in quotes, which I appreciated because I don't know what the heck normal is anymore. But normal, if a child's normal, kind of at a younger age, infancy, can behaviors or can kind of development issues arise later on in life related to substance use? That was from in utero.
Say that again. A little bit louder.
Okay, so basically they said, can a child start to develop more issues, more behavior, developmental delays later on in life that literally didn't kind of show up in those first few years? Can it take longer to show up and still be related to chemical exposure?
Absolutely. Let me give you, for instance, as a social worker who worked in the schools, we would see referrals to the school social worker. And again, this is some years ago because I'm old, but we saw a lot of referrals when they first entered, so kindergarten or first grade. We saw a lot of referrals again in 4th grade and a lot of referrals again in 7th grade. Why is that? Because the level of learning difficulty ramps up in those grades. So the expectation by 4th grade, we are getting away from simple addition and subtraction and getting to much more difficult math. So we tended to see more kids getting referred. You get to 7th grade, you're getting into things, again, conceptual pieces like algebra. So So there are pieces that we aren't going to see right away because, you know, that the child was able to keep up. But as the child is asked to do more and more abstract things and be more and more independent, they may not be able to do those things. So absolutely, there are pieces that we won't see right away. There are pieces that, you know, just like in trauma, there are pieces that the child may do really well with some early intervention. And everybody's saying, this is great, child's doing great. They hit adolescence and they get that hormonal poisoning that happens in pubescence, and it just blows up behaviorally. So yeah, there are things, normal as a setting on the dryer. You're right.
Yeah.
It's
and they all work differently, they said, which is so true, right?
Yep, that's right.
Anyone who's shrunk their favorite sweater gets that, right?
Yeah, amen.
There is no such thing as normal, even on a dryer. I love it.
Yep. So we will be doing, next week will be our last week. And one thing that I have asked Amy is that after our last session, I would really love it if she would do a little bit longer evaluation. So know that this was not Amy's idea. This is my idea.
You know who to blame, right?
I get the blame because since this is a different format than a lot of what we've done, I would like a little more in-depth evaluation so that we know
deeper dive
what you're actually taking away. So we will be back next week. We're going to talk about self-care. How do you take care of yourself? Because guess what? Nobody else is going to do it. And here's a great idea about timers and alarms. Because yeah, for a lot of these kids, transitions are very difficult. Transitions are difficult. I know with my kids, you know, and again, I'm an extrovert and I use a lot of vocal variety, but we had songs for everything. So, you know, when it was time to clean up, we were always singing while we were cleaning up, because it just, having kids have something besides their mother's voice was always very important. So, I think that's probably it for tonight. And we will see you next week.
Indeed we will. So I think it's ironic that your phone had a little ring to it after we were talking about timers, because we have more than met our time this evening. So thank you all for tuning in. Many of you 5 weeks in a row, which is just crazy amazing that you've taken the time to do so. So we appreciate your time and sharing your evening with us. We'll be back next week for one more. Like I said, please share those other thoughts, because as we've continued, we're going to continue to do webinars. It just won't be, 2 Thursdays from now at this point. So I wish everyone a safe, and healthy week ahead. And we'll be back next week to talk about how you can fill that cup, right? Because we can't pour from an empty cup. Great. So have a wonderful evening. Take care, everyone.
All right. Good night, everybody.
Mm-hmm.